Welcome to AETCM, the emergency medicine channel. Today we are going to discuss about an elderly male, 65-year-old male who came to the ER with complaints of lower abdominal pain and unable to pass urine. Initial on triage area, the patient's BP, as per the BP and heart rate, he was triaged into green area.
Okay.
So coming to the history of the patient hadn't been able to pass urine for the last 12 hours. And constipation is also present. He complains of lower abdominal pain and unable to pass urine and unable to pass stools for last 12 hours. Patient is a known case of type 2 diabetes mellitus and hypertension, and previously has been diagnosed with benign prostatic hyperplasia, was evaluated, and for which he has been taken medications for 1 month duration and had withdrawn after he got relief from the symptoms.
Oh, he stopped the medication.
Stopped the medication. Okay. That was 6 months ago, sir. Right now, the patient came to the ER, on examination wise, lower abdomen, we can palpate the bladder. Bladder was palpable till the umbilicus, and no any signs of rigidity or guarding. Bowel sounds were present.
Okay.
So we went ahead with as the patient was having urge to pass urine, unable to pass urine, we've had to first intervene in the way of catheterizing the patient.
Okay, so a 65-year-old male, we'll just brief it, 65-year-old male, known case of BPH, stopped medications. Now he has come with an acute urinary retention since last 12 hours. So that's the background history. He's in green triage category. So when you examine, there is a palpable bladder. Now you have to relieve his symptoms. So that is our main idea. Okay.
So immediate arrangement for the Foley catheterization was done. The 14 French Foley catheterization was 14 French Foleys was used for catheterization and was catheterized. During catheterization, there was a slight obstruction to pass the tube, but it was successfully catheterized.
Okay.
No any signs of any hematuria or bleeding per meatus.
Okay.
And 1100 ml of urine has been drained within the first 10 minutes.
Okay. 1100 ml of urine. So that is a very significant amount of urine that the patient has produced. So one of the most common thing that you will see in emergency room is acute urinary retention. So whether we'll have a facility like this, it is very easy for us. We can catheterize, maybe we can do an ultrasound also later on to assess all the size of the bladder, everything we can do. But in a peripheral setup, so how will you plan the treatment of the patient, whether he need to go home with the Foleys or can we remove the Foleys and send him home? So how will you categorize the patients depending upon their further management?
Usually, like post catheterization is the relieving the urinary retention.
Either by a Foley's catheterization or you have to sometimes SPC. Okay, these are the two options that you need to drain the urine. So that is clear. So most commonly with a 14 French or a 16 French catheter, you will be able to catheterize. So preferably you use a smaller size initially. There has been instances where we need to pass a feeding tube to drain the urine. So our primary thing should be to relief of his symptom. So you have to drain the urine. So if you are able to put a Foley's catheter, okay, well and good, acceptable. But if at all you are not able to pass a Foley's catheter, at least pass a feeding tube and drain the urine out. So that will be our priority. So we have done that. Right. Now the question asks, you have put a Foley's catheter. The patient is asking you, what should I do now?
Next, depending on the causes, if it is a neurological cause or if it's a chronic urinary retention, such kind of patients can be sent for further evaluation with the tube in place.
Okay.
But if it's an acute case, if it is sometimes UTI also causes urinary retention, prostatitis causes urinary retention.
Okay.
These kinds of reversible conditions, once if we diagnose them, we can just start with antibiotics and immediately remove the Foleys. So you can give trial of.
So if the patient had drained 1100 ml of urine.
In this case, as it is 1100 urine.
So when will you say, okay, I can remove the Foleys? You remove the Foleys and send him home. When will you say that?
If it is less than 200, we can definitely say we can remove the Foleys.
Yeah.
If it is more than 400, it definitely requires a urology evaluation.
So that's what the most important thing. The amount of urine that has been drained initially within the 10 to 15 minutes. What is the amount of urine that is being drained? If it is less than 200 ml. Maybe you can remove the Foleys and you can start him on an alpha blocker. If it is definitely you're sure it is a BPH or if it is a UTI related symptom, you can treat and you can send him home. But other group of patient who has above like 400 ml, you need to catheterize them at least for 3 to 5 days. So what usually they practice is 1 week. They will after that they will do a trial removal of Foley's catheter, and if the patient is able to pass urine, well and good. Meanwhile, you have to look in for the causes why the patient had a urinary retention. So the most common reason for a acute urinary retention will be benign prostatic hyperplasia or hypertrophy, whatever you name it. And in this patient, already he is a known case. So you need to start him on an alpha blocker, and later on, definitely we can plan for a definitive procedure, either a TURP or
surgical.
So complete, there are now laser treatment, everything has come up for prostate. So they will just remove the whole prostate as such. Just like you are peeling off an orange from the inside, you are just taking the flesh out of the orange. The capsule only will be retained. The rest, all the prostate tissue they can remove by laser. So that is a newer treatment that is coming. So my question here will be, which all patient needs an antibiotic? When you are planning to send him home, which all patient you will send him with an antibiotic, and what are the other instructions that you need to take care?
Initially, these patients who had recurrent kinds of urinary retention definitely request prophylactic antibiotic, and such patients, when they come to here, we need to send for a labs even to see the counts, whether they are elevated or not. If the counts are elevated, definitely that can be a source of infection. So we start with an antibiotic.
What antibiotic you will prefer?
We can start with fluoroquinolones, or we can start with the ceftriaxone if there's.
Okay, so basically you're planning of an OP management. So quinolones, or you can even oral cephalosporins like cefixim, anything you can give to them. So these are the basic. You understand that it is all gram-negative organism. So when you're planning to give an antibiotic, your antibiotic of choice should be covering that. So either a fluoroquinolones like ofloxacin, norfloxacin, or even levofloxacin you can give for this patient. And only issue elderly patient. So there might be a risk of inducing seizure, because the quinolones can cause decrease in seizure threshold. That is very, very rarely we will see, but that is only one thing that we need to keep in mind. And also, when you are using the quinolones, the problem is that the patient has got a chronic UTI. We need to keep into consideration of a tuberculosis. So these are all second line agents. So even if simple thing we are giving norfloxacin and ofloxacin for a young patient, we are okay. One episode of UTI. But if it's a chronic UTI, always keep in your mind whether are we dealing with a tuberculous UTI. So that time maybe we don't prefer initially to start quinolones. Maybe you can go for cephalosporins or even sulfur drugs. They are also very good having gram-negative coverage. So you have to give an agent that has got a gram-negative coverage, and think also in terms of tuberculosis. So that is regarding your antibiotics. And if it's definitely in sepsis and septic shock and all, you need to admit, and parenteral antibiotics you need to give. Which all patients you will not catheterize? He has come with acute urinary retention. Which all group of patient I will not catheterize him unless and until I have got an expert help, or you have something else.
If it is a post-op case of urethral damage issue during the surgery, if that, or if it's a trauma case, bleeding per meatus, then we should not be catheterizing. We can try for SPC so that
So the issue that will have to happen, if the recent prostatic surgery or recent urethral surgery has been done, it should be ideally done under a guidance of a cystoscopy. So you should use a flexible cystoscopy and urethroskopy or what thing, and you need to catheterize those group of patients. So whenever, don't play with the patient. That is my consideration, because sometimes 14 French will not go, 12 will not go, even feeding tube will not go. So even when an expert fellow who has done enough catheterization is unable to catheterize, you should call for help. 2 attempts you are not able to do, you call for help, and with the help of a scopy, or else he might need a suprapubic catheterization. So that is the main important thing that you need to remember. Prostatitis, it is actually plus or minus whether you should catheterize or not catheterize. That has been a query. But definitely if the patient is coming with an acute urinary retention, definitely we need to catheterize that group of patient. And as you said, blood in the meatus. When you are suspecting a blood in the meatus, or you are seeing a scrotal hematoma, you are suspecting a probable urethral injury, and sometimes there might not be a urethral injury. Suppose you are catheterizing you are suspecting a pelvic injury, you are catheterizing the bladder. So what is the worst thing that can happen?
It can worsen that,
one thing, it can cause a direct injury. Suppose, imagine that there is no urethral injury, you are able to catheterize a patient, you are suspecting a pelvic fracture, but there is no signs of urethral injury, you have catheterized the patient. After catheterization, the nurse is coming, sir, the BP is only 60/40.
Then the direct damage was there.
No, that is the problem is that when you are decompressing the bladder in case of a pelvic injury, see the pelvic hemorrhage is basically due to this venous plexuses. It is not an arterial bleed. So what is happening? This bladder is filled up and it is acting like a tamponade effect over the blood vessels. Suppose suddenly you are draining out the urine, the patient can go into the tamponade effect is lost and the patient can go for an hemorrhagic shock. So you have to be careful when you are catheterizing a patient with a pelvic trauma. Even if there is no contraindication, you have to be careful when you are doing this. The patient can go in for a sudden worsening of hypotension. So that is one thing for pelvic trauma. So the next thing, even normal patient, when normal patient, if you catheterize, they can have hypotension, but that will resolve within some time. The patient is on some medication or they will just recover after maybe 15 to 20 minutes. It's just a transient thing. So that is the most important thing that you need to remember. Then after catheterization, as you said, you have to look for the causes. Can you enlist, we sold benign prostatic hypertrophy. What are the common drugs that we use in our day-to-day activity?
The medication, like sympathomimetic drugs. Suppose they're using nasal drops, phenylephrine kind of things.
Antihistamine. The most common one is antihistamine. Because of an LRT, URT, somebody has given them antihistamine. That can precipitate. Then
like anticholinergics can cause this reduced.
So the most important thing for an emergency physician, I will tell, when you are seeing a patient with organophosphorus poisoning, first thing you catheterize the patient. You are going to start on atropine infusion, which is going to cause retention. So before that, you catheterize the patient. So first, immediately you have to catheterize. So these are all tips that when we see organophosphorus patients. So don't delay Foley's catheterization in this group of patients. Then what are the other group of drugs? Opioids, very common to cause this issue.
Then even
anti-Parkinson's disease. So elderly age group, this group patients are all this risk factor because they might have Parkinsonism. So you look for the cause why this patient has got this urinary retention, and you have to chase behind that, and probably you need to start them on an alpha blocker. So what instruction you will give to the patient? You are discharging from the patient, you are sure the same patient, you are discharging him. You have started him on tamsulosin and you are asking him to go home. So what instruction you will give to him?
Initial instruction, as in this case we are suspecting benign prostatic hyperplasia, we can discharge as the volume of the urine which was drained was very high. We will discharge along with the catheter. Along with that, first dose of alpha-1 blocker will be given in the ER itself, and we will start to continue for the next 1 week. Few days we will ask. Along with that, even 5-alpha reductase inhibitor finasteride also will add.
So common combination will be
tamsulosin plus
with finasteride. There are newer group of like silodosin with dioxazide combination, silodosin D.
Long acting.
A lot of medications have come recently. So any of this drug, you have to start them. But my question is, what additional instruction
would be like after 1 week of duration to review in the urology to remove the...
Today, what you will give the instruction? Today, the day one, he is taking the postal hypotension. That is, alpha blockers are very notorious to cause this postal hypotension. So they will definitely, right now it will not happen because they are on catheter. But after, if you are planning to start on an anti-alpha blocker and you are sending home, they will definitely wake up at around 2 a.m. to go to the washroom. For this patient, it is okay because there is a catheter in place. But he need to, sometime he go to the toilet or suddenly he can wake up in the midnight. So he can have a postal hypotension. So that instruction you should give, sit over the bed for next 2 to 3 minutes. And after that only he should start walking. That instruction should be given to the patient as well as to the bystanders. So such an incident can happen. So make sure that he is not immediately walking after starting because there is a possibility of postal hypotension. So that is one instruction. Then next he need to have a urology evaluation. After maybe 5 days he need to go to the urologist and get it done. When will you do a PSA assessment?
PSA should not be done at the time of acute urinary retention because there will be increased PSA false positive value.
Whenever there is infection, whenever there is acute retention, don't do at that point of time. Later on, after antibiotics or subsides, you do a PSA. And if it is grossly evaluated, definitely he needs evaluation. And always make sure that a rectal examination is being done for this patient. Because if the prostate is very hard and all, you have to think in terms of an underlying prostatic cancer. So that are the red flags. We can call it as red flags for acute urinary retention. What will be the other red flags? associated neurological weakness. There is associated neurological weakness, that is again a red flag. Whether we are dealing with anything else, whether we are dealing with a spinal compression, spinal cord compression, back pain associated with back pain, paresthesia and numbness, these are all red flags for acute urinary retention. We can call it that way, yes. Red flags. So this group of patients definitely require an more and more evaluation. Then what else you wanted to do for this?
Regarding the discharge, there is another complication of catheterizing and acute urinary retention is post-catheterization diuresis. Supposedly in adult elderly people, if it is coming 200 ml per hour, for the next 2 hours, then we should consider it his post-voiding diuresis is happening and we need to hydrate the patient.
Well.
That is one other complication.
And hematuria.
Hematuria will be...
the most important problem is that the junior most person is catheterizing, and what will happen? They will inflate the bulb inside the urethra and urethral rupture. So that makes sure that is not happening. Making sure that till the V, the catheter is going inside, and then only you inflate. And if you have an ultrasound, just confirm with an ultrasound. You think that, why he is telling this? But very common problem, urethral rupture. Sure. So we are seeing a lot of patients referred from other hospitals who have been catheterized. But if you have an ultrasound, use that ultrasound and make sure that the bulb is inside the bladder. So this is one simple thing. There is no recommendation as such, but when we have a facility, use that facility. Patient safety is the priority. We should not be causing any harm to the patient. Okay.
Also, before catheterization, if you're having a bedside ultrasound, we can calculate the volume of the bladder to confirm if there is any bladder pathology, because it will be full size bladder.
So the basic idea, acute urinary retention, our aim, drain the urine first. Either a Foley's catheterization or a suprapubic catheterization. Suprapubic catheterization, routinely when you require, will be very, very rare. Maybe less than 1% of your acute urinary retention that is coming to the ER requires an XPC. But when you are suspecting a urethral injury, when you are suspecting a recent prostatic surgery, they don't want to catheterize him, they might go for a SPC. Fine. Anything else you want to add?
Nothing.
Yeah, fine. Thank you.